Dr. Raj Verma from University of Connecticut to be our guest speaker today. Dr. Verma obtained his PhD from Central Drug Research Institute in India and was trained at Yale and University of Connecticut, where he is currently working as an assistant professor. I will let him tell what he's doing. This, Raj?
Oh, no. Can you hear me?
Yeah.
Yes. Good morning, everyone. As Dr. told, I did my PhD in drug discovery from CDRI. And when I came to here, I joined a lab of Louis McCullough and continued my stroke research. So today I'm gonna, I'm working on the stroke research from my PhD and I'm continuing it so far. Today I'm gonna tell you. Okay, so though we know that, there are very few treatments for the stroke. Okay, so one is TPA and another is mechanical thrombectomy. Other than that, we have not explored other treatment options. So here I'm going to tell you about one of the novel potential treatment options for the stroke, which is a surgical method. And I will appreciate your feedback because this is really new for me, as well as I don't think anybody do in mouse model. It's done in the here in the moyamoya disease, which I will tell you later on. So okay, sorry. So this is my outline. So I will introduce you a little about stroke and current treatments. Something about angiogenesis, because this model actually helped to get the new blood vessel formation, and then the surgical approach and some of my preliminary work on this model, how to create this model, and some future directions. So if I don't need to introduce in detail about what is stroke, but when it occurs when there is a disruption of blood supply to the brain, and we all know it's the fifth leading cause of death and number one cause of the disability world over. Stroke causes almost 160K death in US, and this is like 41 deaths per 100K. And the related cost is humongous or very big. So we need the treatment. So in order to get new treatment, we have to create this model in mouse so that we can test the new drugs. So and we have different kind of strokes in the clinical setting, which is ischemic stroke and hemorrhagic stroke, and then two subtype of hemorrhagic stroke is intracerebral bleeding or hemorrhage or subarachnoid hemorrhage. So my lab study this ischemic stroke, which occurs due to a clot formation or occlusion of the blood vessels that lead to damage in the brain tissue. Because I was told this is educational ground, so I thought I will add some of the mechanisms that lead to ischemic stroke, which is formation of blood clot, atherosclerosis plaque, or embolism. And I think I will skip it for now. And these are the impact of the this injury on different functions. So you lead to neurological deficit, disability, and increased risk for actually future strokes. So and then now I want to focus more about, because in mouse model we study a lot of pathophysiology and mechanism. So what happened after stroke? Immediately after stroke, the blood supply stop, ATP is reduced, and what it lead to sudden neurological cell deaths, especially the vulnerable neuron die first, and these cell death release a lot of the damp molecule into the parenchyma, and these molecules actually activate the end macrophage, which are microglia and other tissue macrophages, and activation of these macrophages lead to pro-inflammatory cytokine release, MMP activations, and activate endothelium, which actually ultimately lead to blood-brain barrier disruption. So once you have a blood-brain barrier disruptions, this also actually attracts peripheral leukocytes into the brain. They further exacerbate the damage. And then this leukocyte infiltration or lead to neurotoxicity and further contribute to neuroinflammations. So this is in very brief. So what happens? So this is during the acute and subacute phase, and over the time, the resolution phase starts. So anti-inflammatory phenotypes of the macrophage. So environment lead to actually activation of same macrophages, try to release some anti-inflammatory cytokines that leads to resolution phase from tissue repair, neurogenesis, angiogenesis, and clearance of damage. So this is the whole cycle. So goal of our in pain clinical setting as well as clinical setting is to reduce the acute inflammation and to exacerbate or to enhance the clearance of damage, increase neurogenesis and tissue repair. So that the timeline, because the time is very critical, more time they are exposed to these damaging molecules, they might get more damage in terms of the brain tissue. So we want to rescue as much as the brain tissue. So this is just a summarized view of current treatment. As I already told you, during the emergency treatment, thrombolysis using TPA is the only available drug treatment, and another is mechanical thrombectomy. But these both treatment has limitations. So one has like very short, narrow treatment window, and other has little bit bigger treatment window, but they only accommodate almost like 5 to 15% total population. So other 85% don't get any type of the treatment. So only they get the rehabilitative treatments or some symptomatic relief from using or precautionary medication like anticoagulant, antiplatelet drugs, just to revive. Or we have to change the lifestyle or dietary changes, if we want to get protection from the the further or any subsequent stroke. So I will highlight here the surgical treatments, which I believe you guys you might be aware about it. So during stroke, what happens? The foremost goal of the clinician is to restore blood flow in the damaged area. Okay. So to restore blood flow, you have to have a perfusion system which can provide a blood supply, continuous blood supply to that area. But unfortunately, after stroke, these blood vessels also get damaged. So the continuous blood flow is not there in the ischemic core area or even in the penumbra area that I will show you later on. So now there are different ways how can we increase the blood perfusion. So increase the blood supply. The already established methods are endovascular thrombectomy and carotid endarterectomy. So which you already know that they remove the clots from the carotid artery, or endovascular thrombectomy is just the retrieval of clot like we do it in heart. So same way we do in the brain too. But the thing that I'm going to explore more about is this intracranial, extracranial EC-IC bypass, which is actually a technique to reroute blood flow to the blood vessels in the brain. So to do that one, there are 2 or 3 techniques. There are 2 methods, direct methods that involve the connection of the healthy blood vessels, mostly from the superficial temporal artery, which is artery in the temporal muscles. And then they expose the brain surface, and then they connect it with some of the blood cerebral artery. So it's like very sophisticated surgical techniques where they connect a healthy artery from the temporal muscle to the cerebral artery. I think superior to the clotted area or superior where the narrowing of the blood vessel occurs. And there are another method is indirect method. So indirect method involves extracranial blood vascular supply in the proximity of the brain surface, which is further can be divided into 3 subtypes depending on their nature. So in this method, they apply a tissue or a blood vessel, but they don't directly suture it with another vessel to establish a quick. So this is more quick and this is more slow progress to show the reperfusion or increase the reperfusion or blood supply in the area. So EMS, which is gonna be my work. So this is encephalomyosyngesis. As you say, name itself suggests that you are joining muscle to the brain surface. Encephaloduroarteriosyngesis and encephaloduroarteriomyosyngesis. So combination of these first two is encephalomyosyngesis. So this one is directly applying the muscle, intact tissue, intact temporal muscle on the brain surface. So they don't use any blood vessel separation and then connect it to the brain vessels. So they directly put this muscle, and this muscle is highly vascular. So the blood vessel will grow in the brain surface and then provide the blood supply over the time. In this, the second method is they take one blood vessels, most probably HTA, and then overlay after dissecting dura, and they overlay on the brain surface. So just taking out the blood vessels and putting on the brain surface, over the time it will create new blood vessels from it, and that will supply the blood flow in that area. And the third one is a combination. So they put muscle as well as separate the vessels and then put it on the surface. So my lab do encephalomyosyngesis. This is very commonly used surgical treatment for moyamoya disease, which is a progressive occlusive disorder where you have the progressive narrowing of blood vessels that often lead to stroke. We don't have so many cases in US of moyamoya, but in Asian countries there are more. They're more prevalent. So we wanted to use these techniques in case of the ischemic stroke treatment. And this idea came from, I will tell you later, from a neurosurgeon who was who do a lot of this type of surgery. And he came to me and told me like, okay, we want to create a model in mouse so that we can test the proof of concept study so that whether this model will work in stroke cases or not. So I was presenting somewhere the stroke work, and I was showing my model like how we create. So he wanted, can we do this model with your model and see if there is any neuroprotection or not. So we started to learn this model. So anyway, EMS has been shown, improving the clinical symptoms in moyamoya disease, and but as I told you, in non-moyamoya stroke, like ischemic stroke, we don't know whether it's going to work or not. So we started this technique, in mouse model to generate some proof of concept study. So as you can see, this is an angiogram in human. So you can see after here, after you do the EMS surgery, you see this lot of blood vessels generates. And similarly, when we saw in stroke cases in mouse, so this is a coronal section of mouse brain, and then we saw that this is the healthy tissue. We have a lot of vascular network here, but this is a stroke tissue, which you can see here, and then surrounding this area is the penumbra area, where there is blood supply, but not as prominent as in the healthy tissue. So what we are doing in the next subsequent slide, I will tell you how the EMS is applied here and how they increase the blood vessel supply in the damaged area. Before going into that one, so this is not the only one aspect that people have tried to increase angiogenesis, because they want to have the more blood supply. So to get the more blood supply, they have to create new blood vessels. So ischemia itself leads to actually the environment that leads to angiogenesis, because it creates hypoxia. Hypoxia leads to VEGF secretion, and that leads to. However, it is not sufficient enough so that it can give a blood supply. Similarly, the VGF treatment has been used in clinical practice to like not clinical, so in various preclinical trial as well as in clinical trial to increase angiogenesis, but it might lead to blood vessel formation, but those blood vessels are often leaky, and the network they create is uncontrolled. So that was not able to create a environment that can lead to actually control angiogenesis that might actually improve the blood supply as well as and later on the neurological functions. So most of the leaky blood vessels lead to a lot of edema formation in that area after they applied the VGF treatment in both mouse model as well as in human model. So there may be a limitation when they applied the VGF. If you applied early on, it might lead to more inflammation. If you applied little bit late, it might be helpful. However, VGF has not been successful clinically, so they are coming back and find out what are the other things that we can use it. So here I'm proposing this model, like we can have a more vasculature by healthy tissue. So they secrete not only the angiogenic but also anti-angiogenic substance to counteract those. So they will create a natural environment of angiogenesis. And there were other, limitations of using this VGF therapy was like, anterior venular malformation, because they create angiogenesis, but sometimes the connection is between artery and the vein, and difficult route of application and short half-life of other regions of the field treatment with VGF. So, Ketan Bulsara, who is a neurosurgeon in Newcon Medical School, so he actually brought this model from Yale to my lab, and then he showed me how to do. So in this model, we first create stroke, and then we take, in this next slide, I will show you, then we take this muscle and remove this bone on the brain surface. So we are just joining this muscle and removing this cranial bone between the muscle and as well as dura, and then joining those. So after this, and we leave the mice for recovery for long term and do a lot of histological and functional behavior tasks to see if this method improves blood supply in the brain or not. So this is our model. I'm sure you are familiar with this MCR model. So we create a model through this internal carotid artery, take the suture up to the origin of middle cerebral artery here, and then block it for 1 hour, 2 hours, depending on the time, and then reperfuse it by taking it back. And after this reperfusion, so it creates ischemia reperfusion injury and lead to cell damage. You can see in the TT stain in the mouth brain, as well as just to show a similarity between human CT scan, you can see that this is the damage area, which is this model is more or less able to create a similar damage in mouse. So, and it leads to different zones of blood flow here in the core. There's almost no blood flow, a dead area, which is hard to rescue, and there are different zones around this core area that's called penumbra, and depending on the blood flow, how much blood flow is there, we can subdivide into different zones. So these are the area, these penumbra, that we are trying to rescue with the help of this model, angiogenesis EMS model, or even any treatment want to rescue this area so that the damage is limited to the core area. So after creating a stroke model, so between 4 to 24 hours, we do this EMS surgery. So we tried both 4 hours after or 24 hours after. So what we do here is in this model, we just between the eye and ear, this is the temporal region. So we remove the skin and then identify temporalis muscles. So after temporalis muscle, we actually retract the muscles without detaching it. So we just retract it back, and after retraction, we do craniectomy to expose the brain surface. So somewhere between 3 to 5 mm hole, so that you have enough surface area. And then once you expose the brain, you pull it back. So you see that we lay over this muscle on the brain surface, and then connect it with the soft tissue under the skin here, and then we suture the skins and leave the mice. So this gives indirect benefit, because this model how we can apply in human cases. So if you know that in almost 10% of the large hemispheric stroke, we have to do craniotomy to reduce the edema or the pressure. So in those cases, it can be easily applied. You just have to put the muscle over it, and then you might see some benefits. So whether we will see those benefits or not, we will test it in our model. But this is how we can use clinically this model, at least in those strokes where there is a lot of injury and you do craniotomy to relieve pressure or edema formation. So these are some evidence of if the muscle we attach. So in the first we try to see when we are grafting this muscle on the brain surface, we try to do minimum injury to the muscle, but still we need to check if the muscle is healthy or not. So we use NADH staining to see if there are damaged cells or not. So we did not see any damage, significant damage in the grafted muscles. There was some decline in some injury due to surgical manipulation initially in few days, but they recover very well after 21 days. So after testing the muscle is good, healthy, we want to test if this muscle is making any bonds with the brain surface. So we use immunohistochemistry, after dissecting the brain together with the muscle, and to see if the blood vessels you can see in the healthy tissues, and then you want to see if they are going into the brain surface or not. So here is the healthy just EMS, and then no stroke here, but just we try to overlay this EMS muscle and whether they make bond or not. So you can see the alpha skeletal muscle actin, which will indicate actually the the smooth muscle cells of the blood vessels from the EMS, and then lysoperfusin esculatum TD-lactin. So this is the lactin dye that we usually use in preclinical setting to actually check if this is blood endothelial or not, endothelial cell or not. So as you can see in the second picture here, then this muscle makes a bond with the brain tissue, and we can see that there is a connection going on between. I don't think in this picture here we show, but we have done multiple times that sometimes the major blood vessels is going in the tissue and forming connections. Then we also tested whether what type of, so we took the tissue after the surgery, 7 days, 20 days, or 21 days, to see what angiogenic proteins are expressed after stroke, or does the EMS actually increase different kind of angiogenic proteins. So we did angiogenic array by Western blot. First, we saw there are a lot of protein even only after stroke they got upregulated. Okay, so after stroke over the time. However, when we did the same method with just comparing the stroke and EMS model, we found there are two different proteins. There's osteoprotein, which is a inflammatory proteins. So after EMS, it's reduced, so suggesting that inflammation might be less after EMS surgery, as well as this FGF acidic protein, which is one of the angiogenic protein. is upregulated after EMS model. Then after getting this molecular evidence that what protein might be secreted to show its beneficial, we went to go. So this is another array to show different kinds of inflammatory proteins, whether they are upregulated or downregulated. So we found that IL-10 is downregulated, futin A and CXCL2, these are downregulated and upregulated respectively. So they are anti-inflammatory or the inflammatory protein. So this is a combination of variants. So we want to test which different type of proteins are upregulated or downregulated. Just it's like a screening, or just want to see what are going up or down with that one, so that we can make sense of it. And then we went to the direct evidence whether this EMS model. So this is one of the most important observation that we see in the
Yes.
EMS model.
Dạ kỳ.
Is there any- So this is the MCO brain, and this is the ipsilateral side where the damage occurs. So you can see here there is a lot of damaged blood vessel is still there in the area, but after EMS application, we see a lot of blood vessels which generate in the ischemic tissue. So this was one of the most important data that we got, that there is increased blood supply. And this because we use a tomato-lactin diet immediately before sacrifice, and we perfuse the mice with this dye. So this dye will only go in the perfused vessel. So this also suggests that these blood vessels are perfusing. So now after getting this blood vessel more concentration, or more numbers in the ischemic tissue, we want to test if these blood vessels are stable or not. So as we know that even VGF has increased the blood vessel density in the ischemic tissue, but the problem was they were leaky, okay, and they were creating inflammation. So, or they were also immature. So to get the blood vessel mature, they has to have this whole layering of PGRAF positing cells that makes them stable, we can say that whole architecture that makes its blood-brain barrier intact. So, so we wanted to test now if these blood vessels are just endothelial cells layering, or they have covering, parasite covering, which makes them stable. If they are stable, they will sustain and increase the blood flow, and then there will not be any inflammation. Should not be any inflammation because of the leakage. So we did actually co-labeling with the PGDR beta, which is a parasite marker. So up to 30 days, we did not see any blood vessels. Actually, you can see here there is no co-labeling with this in the new vessels. The co-labeling with this PGDR beta. However, when we extend this EMS surgery up to 60 days, or let the mice survive for longer time point, we see these blood vessels were having the PGDF covering after EMS, which we did not see in the stroke model. This data, this preliminary data, so we are still doing this model. This preliminary data suggests that these blood EMS increase vascular supply in that area, increase the blood vessel density, as well as these blood vessels might be stable, so may not be leaky. So we have to do more experiment to find out if there is overall inflammation is reduced or increased, or there are any change in functional recovery or not after this model. So we started to do this functional recovery. So this is one of the data which we are showing that the F4/80 is a macrophage marker, and then we try to see if macrophage coverage is reduced after EMS model or not. So as you can see in this one, there is less F4/8 positive area, suggesting that there is a limited damage area after EMS, which suggests that it might improve the histologically, so it can restrict the damage to spread, as well as we use some sensory motor function task where actually we use the rotor task in which a mouse is kept on accelerating rotor and see how much time it takes to fall back. So longer it stay means they have good sensory-motor functions. If they fall down early, they have less, so they have deficit in the sensory-motor task. So this is some early data. So we have only tested up to 21 days. We are doing for long term, but we saw this. There's an improvement in the sensory-motor function after EMS surgery, and because this is a very invasive model, you open a brain in your bone, and then you dissect the muscles. So in addition to your surgical model, so we were thinking that there will be more mortality, but surprisingly, we did not see additional mortality with this EMS model. So this data says that this is a very tolerable model. So we can apply easily in mouse model, and we did not see any increased mortality. So with that, I will summarize my preliminary data. So we are still trying to establish this model in our lab and try to find out what parameter we can test if this model works or not. So I will get your suggestions if you have anything that we can improve this model. But we have shown you evidence that temporous muscles remain viable, and we have shown you evidence that there is increased angiogenesis in the ischemic hemisphere, as well as this is safe and reliable model, and some early evidence of it can improve behavioral functions. So with that, I want to thank you, my lab and other people, Dr. Bulsara, who actually brought this model to my lab, and we started to do this. And most of the work was done by Dalin, he's a AHA postdoc in my lab, and I thank to AHA, especially Transformation Project Award to support this work. With that, I will welcome any questions.
I was wondering that, I don't know whether I missed this part, but then I was wondering that what was the time point that you did the EMS surgery?
4 hours. The data I told you is 4 hours after.
Yeah. Do you think is it like the time point of the surgery? Let's say if you do it at a later time point of like the surgery.
So actually, this is a very interesting point. I tried to do after 24 hours. So when I did after 24 hours, there was a lot of edema. And when I did the craniotomy, the brain spoke out like a mushroom, because it was so much pressure there. So EMS itself, just without implanting the muscle, the craniotomy might help to relieve the pressure and care. However, what I found is because already there's a lot of damaged tissue by the time 24-hour damage is done, and when we implanted muscles, so we did not see a similar benefit that we saw 4 hours after. So angiogenesis, the treatment need to be, we will do later on time points, but at this time point we did not see any any improvement when we did it later on. Maybe several reasons, the damage was too big at that time, so we implanted muscle on all the damage, that may be all 4 regions. There was no penumbra to actually the muscle to make the connection. So we need some penumbra area so that they can make connection with some of the impaired blood vessels, and they can reach.
For the motor assessment, what was your opinion?
What was?
EMS versus control, or sorry, just the
rotor rod testing.
Oh, rotor rod test. 0.05 lakh. You are P value.
Yeah.
Less than 0.5.
In terms of the sort of applicability of the mouse model, a hemispheric stroke in humans has like a 80% mortality, and you had like a 20% mortality mouse model by itself. Why are they so different?
So,
Not 8-year-old mice.
so
They're young, healthy mice.
yeah, we are using in this model we are using most of the clinical patient cases occur in the age, so they are more vulnerable for them. And Dr. might know very well, these mice, even we show that half of the hemisphere is gone, they are very resilient, they survive a lot. And there is a lot of plasticity in the brain, in mouth. They make connection with they get support from the contralateral side, and they still survive. So it's true that in this model we don't get that much mortality, but they're very plastic, young, healthy mice.
So mice are very different than humans because of their immune system. See, mice live in gutters, right? And so even after
Focus from humans.
so after stroke, particularly, most of the patients probably they don't even open their eyes for 2-3 days. Whereas mice, you induce stroke or TBA also. Within 6 hours, they will get up and start eating. I have a question, Raj. Maybe a dumb question, but my understanding is that in the skull there is not much space except the brain completely fills the inside the cavity. So when you took a piece of muscle and put it next to the brain, how do you create the space to do that? Particularly after stroke, the brain is also swelling.
They leave the skull off.
They
take the skull off.
Or he takes the skull off.
So yeah, so we retract the temporis muscles, pull it back, then we create space between, and then we do anatomy.
What are you doing? I just do this.
But you put the skull piece back or ever.
No, not that.
So that
Not in mouse. It's
translational therapy, right?
Sure.
So we do it.
Yeah, we do it all the time. I did this 2 days ago.
yeah. So my neurosurgeon did receive that.
I guess the muscles run away. Yeah, we did this Saturday.
So in human, they also stitch it back. They just leave a little opening, and then muscle goes through that.
We're big also.
In mouse, the skull is so thin you cannot put it back.
Okay, thanks.
And even you cannot suture the dura. It's just very fine. You just touch with the forceps, it goes. Unlike in human, like you can stitch it back.
Dr. Verma, I have a question for you.
Yes.
Sorry, I couldn't hear very well online, so it may have been asked before. But one of the theoretical risks of EMS in humans has been when the muscle contracts, that it could cause damage to the brain. Could you discuss that?
Sorry, I could not understand.
In humans,
Yeah.
EMS, what can happen late is the muscle contracts, and there's some concern that traction could cause damage to the brain.
Okay.
In your model, you're not waiting that long, so it's.
Yeah. So actually, they are intended the mass effect of EMS surgery in human. So they, to avoid that effect or during the retraction, they actually split the muscle.
Right.
To reduce that. So I'm sure that they might be doing this.
Yeah, it's a later. Your model wouldn't address that.
Yeah, because it's very fine. We cannot take it into there.
Well, and also you're not waiting long enough for it to retract.
Yes. We are doing up to 70, 80 days. We did not see that one, but maybe we're just starting to do it. We have to let the mice survive for like 90 days or more to see that type of thing.
I guess, sorry, Santi, but I guess we're good. Thank you very much.
Thank you so much.